Good afternoon, everyone. To those that are new to the Echo space, welcome. And to those that are returning, welcome back. The TxRx Echo is brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley. My pronouns are she, her, and I will be the facilitator for today's session. A few housekeeping items before we begin. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We do encourage using the chat and/or the raise your hand feature to pose questions or share your perspectives throughout the session today. If you are having any connection issues, please privately chat Karen, our wonderful Echo IT, for further assistance. And as a note, these sessions are being recorded and they will be shared on our website. So therefore, to ensure privacy, no personal health information is allowed at any point during the session. And this includes names, addresses, birth dates, or any other identifiable information. At the end of the session, the Echo team will send out a post-session survey link. We kindly ask you to complete it as it provides us feedback on how to refine these sessions to better serve you and better address your priorities. So finally, Echo is an all teach, all learn environment, and we do encourage everyone to participate in the conversation and raise questions. Let us always make every effort to avoid bias and stigmatizing terms so that we can continue having a space that is safe and respectful for everyone to learn. With that, we'll go ahead and move on to some brief team introductions. I will go ahead and start with Dr. Walker.
Hi, good afternoon, everybody. Hope everyone is staying safe and warm today. Crystal Walker, I am a doctorally trained PA, and I am currently the Director of Substance Use Disorders, Medical and Clinical Services for My Health, My Resources of Tarrant County in Fort Worth, Texas.
Thank you, Dr. Walker. We'll go ahead and go to Dr. Chowdhury.
Hello, everyone. My name is Dr. Chaudhary, and I am an assistant professor here at UT Health San Antonio. And my specialty is in adolescent addiction medicine, and really happy to be here.
Thank you, Dr. Shorter.
Good afternoon, everyone. I'm Daryl Shorter. I'm an associate professor of psychiatry at Baylor College of Medicine and the medical director of addiction services at the Menninger Clinic here in Houston. Thanks.
Thank you. We also have Dr. Kowalczyk.
Hi, Alicia. I'm with Baylor College of Medicine as well in the Department of Family and Community Medicine, boarded in Family and Addiction Medicine, and I'm also medical director of Santa Maria Hospital.
Thanks, Dr. Kowalczyk. And Dr. Wakhlu, who will also be our didactic presenter for today.
Hi, Sidarth Wakhlu. I'm an addiction psychiatrist, faculty at UT Southwestern, director of the addiction services, as well as director of the addiction psychiatry fellowship here.
Thank you very much. Thank you. And finally, Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal, and I'm the ECHO coordinator. Thank you for joining us today.
Thank you, Jasmine. And if you haven't already, I invite everyone to introduce yourselves in the chat, drop your name, email, and affiliation, and let us know that you're here for attendance. Thank you. So with that, we will go ahead and get started with our didactic presentation. Dr. Wakhlu, the floor is yours.
Thank you so much, Angela. And let me start with Can everyone see my slides? Can everyone hear me well? Angela, is the audio good?
You're good.
Sounds great.
Okay, slides are good. Okay, wonderful.
Yes,
Thank you so much. So primarily focused today on management of alcohol use disorders, and these are my objectives for the talk today. Primarily talk about the epidemiology of alcohol use disorders, talk about some unique aspects of alcohol use disorders in women, especially as we have seen a narrowing of the gender gap across the board with alcohol use in women, and then talk about pharmacological treatment strategies in alcohol use disorders. Henny Youngman he was called the king of one-liners, so he came up with some very nice ones. So where are we as regards alcohol use disorders? So this is our latest data on the National Survey of Drug Use and Health 2023. We have close to about 29 million people in the country, 12 years and older, that have an alcohol use disorder. It's about 17 million men, 12 million women. And what we have seen is, and I'll kind of talk more about this, is that we have seen a narrowing of the gender gap across all age groups. And not only in narrowing, we have seen now that adolescent girls drink more than adolescent boys. And historically, it was the reverse, that adolescent boys used to drink more than binge drink more than girls, but now that relationship is reversed. And in this latest survey, we have about 750,000 youth ages 12 to 17 with an alcohol use disorder, out of which about 480,000 are teenage girls, 12 to 17, and 270,000 are teenage boys. And this is the pattern that we have seen in the last two surveys. And when you look at data from the 1980s, the rates of alcohol initiation, male-female ratio was 5 to 1. In the 90s, it became 3 to 1. In the early 2000s, it was like 2 to 1, but now we have seen that ratio closer to the mid 2000s. It's got to about 1 to 1, and now we have, like I said, teenage girls drinking more than teenage boys. Alcohol deaths have reached a historical high, 178,000 deaths in the country annually. About 110 of these deaths are because of chronic medical issues, alcoholic liver disease, and etc., alcoholic cardiomyopathy, and about 60,000 deaths are for acute injuries, motor vehicle accidents. And alcohol kills more people than opioids and stimulants. They've been in the news, but no one talks about the fact that alcohol kills more people than any other substance, and has been for decades, but it really never makes national news. Besides the 29 million people I talked about, we have 40 million people in the country 12 years or older that have unsafe alcohol use. And again, when I talk about unsafe alcohol use, I'm talking about the current criteria in the country, which is 14 standard drinks for men less than 65, and 7 standard drinks for men over 65 and women. And they are by no means safe levels. Every time we drink, anytime anyone drinks more than 1 standard drink a day, all-cause mortality goes up. And we have seen a rise in alcohol-related deaths in the country since the early 2000s. And so what we see in these 40 million people are increased cardiovascular morbidity and mortality. Especially this risk increases exponentially in postmenopausal women as the benefit of estrogen goes away. And alcoholic liver disease is now the most common indication for orthotopic liver transplant in the country. Used to be hepatitis, but now it's alcoholic liver disease. And 50% of all liver diseases deaths are attributable to alcohol misuse. And we have seen an intensity of binge drinking, ED visits, and hospitalizations in the last 10 years. And when you compare that with less than 10% of people with alcohol use disorders get any treatment, and fewer than 4% receive pharmacotherapy. As a nation, it costs about $250 billion in healthcare costs and lost productivity. And in the state of Texas, it costs us $19.1 billion. 17.6% of Texas adults over age 18 binge drink at least once per month. And an average of over 10,000 annual deaths in Texas are attributable to excess alcohol use. And the narrowing of the gender gap across all age groups, including the geriatric population. So even elderly women are more and more drinking like men. The 5-year average annual rate of excess alcohol deaths per capita in Texas increased by as much as 44.2% from 2015 to 19. And 71.1% of people who die from excess alcohol use in Texas are men. 3/4 of the total cost of alcohol use disorders is related to binge drinking, and more than 10% of U.S. children live with a parent with an alcohol use disorder. So again, with these kids, what we see is the trauma of living in an alcoholic home, and these kids are at an increased risk of developing an alcohol use or a drug use disorder later on in life. Coming on to my next topic, women and alcohol use, and as you'll see in the next few slides, there are biological, social, and psychosocial reasons of reasons for concern of alcohol use in women. Women have less gastric alcohol dehydrogenase in the stomach lining. This is an enzyme that breaks down alcohol when we consume it. So women have less gastric ADH and they have lower volumes of distribution, which leads to higher blood alcohol levels and greater effects. So men and women, same body parameters, women have higher blood alcohol levels and greater alcohol effects. So they're much more likely to have alcoholic liver disease and alcoholic cardiomyopathy as compared to men. Women experience the phenomenon of what is called telescoping, and telescoping was first described in alcohol use disorders in women, but it's true across addictions, both chemical and behavioral. So, what is telescoping? It's an accelerated progression from initiation of alcohol use to the onset of addiction and the first admission for treatment. So, women present with a more severe clinical profile, that is, they have more medical, behavioral, psychological, and social problems than men, despite having used less alcohol for a shorter period. So the onset of alcoholism in women is later, but like I said, they get sicker physically, psychiatrically, a lot more quicker with a shorter duration of use and lesser amounts. Yeah. And women are more likely to develop alcoholic liver disease and alcoholic cardiomyopathy as compared to men. There's higher prevalence of primary mood and anxiety disorders in women with alcohol use disorders as compared to men, and women with alcohol use disorders are also more likely to abuse or misuse prescription medication, especially prescription benzodiazepines. And some social issues related to alcohol use disorders in women. Women have high levels of shame and stigma. We hold women at a higher moral standard as compared to men. So they have high levels of shame and stigma. They tend to be drink in private and more likely to hide their drinking. They are more likely to want treatment, but less likely to get into treatment because of financial barriers, not having financial means, not having the insurance to get into treatment, and they're more likely cohabitating with a partner with an alcohol use or a drug use disorder. And women experiencing intimate partner violence at treatment entry were less likely to complete treatment. So coming on to the main topic of alcohol pharmacotherapy, as you can see in my slide, I have divided them into first line and second line agents. And as you can see there, acamprosate, which is FDA approved, but with very questionable efficacy, I've put them in second line agents because we have seen clinically that there's not much of a value in acamprosate. And I have put agents like gabapentin and topiramate, which are not FDA approved, but which are really some good evidence for use in alcohol use disorders. So. Now, talking about our first agent, disulfiram. Disulfiram has the longest history of use as an alcohol use disorder medication. It was the aversive effects were first observed in the 1930s when disulfiram was used for vulcanization of rubber in the U.S. And so, what happened in an occupational medicine physician, Dr. E. Williams, noticed that when workers went back home and tried to drink, they became violently ill. Similar effects were seen in the Swedish rubber boot industry. And what Dr. Williams did, he wrote a case report and he said, this could be a possible treatment for alcohol use disorders. But again, he wrote the case report, nothing was done. Fast forward 1945, Copenhagen, Denmark. Two investigators, Jacobson and Hall, were studying disulfiram as an antihelminthic for worm infestation. Disulfiram has chemically a close cousin of metronidazole or flagyl, which is a medication that we use to treat worm infestation. So they started studying it, and these two investigators had a habit of trying every medication that they tested. So they both took disulfiram, they went to a cocktail party, they drank, and they got sick. So that was this serendipitous discovery of disulfiram in 1945. They did not initiate any studies on disulfiram at that time, but 2 years later, at the urging of a Danish psychiatrist, they started studying disulfiram in doses of 1 to 3 grams. And again, that's important to know because of what I'm going to talk about in the next few slides. 1 to 3 grams, not 250 to 500 milligrams, that what we use clinically, but 1 to 3 grams a day. And the term antibuse comes from antibus. So, as we all know, how does it work? It inhibits an enzyme, acetaldehyde dehydrogenase 1A1, which metabolizes, which is involved in the metabolism of ethyl alcohol to acetaldehyde. So, when you block this enzyme, and then from acetaldehyde to acetic acid. So, when you block this enzyme's blood acetaldehyde levels rise, resulting in nausea, vomiting, flushing, tachycardia, palpitations, and hypertension. So most disulfram ethanol reactions are self-limited. They generally last a few hours. The point I want to emphasize is that no one dies from drinking on 250 to 500 milligrams of disulfram. They become deathly sick, but they don't die from it. When you review the literature, all the deaths that occurred from disulfram all came from studies in Denmark, where they used 1 to 3 grams a day. And all these rare side effects that optic neuritis, hepatotoxicity, liver failure, peripheral neuropathy came from 1 to 3 grams a day, not from 250 to 500 milligrams. So that's important to know because these scary side effects that we read about in medical school during pharmacology or in our training is just takes us it really it creates a scare, and it prevents us from using a medication that really has a value for a subset of our population. Common side effects are dizziness, metallic taste in the mouth, some urticaria, acneiform eruptions, and headaches. The most common side effects are primarily the dizziness and the metallic taste in the mouth. Its half-life is long. It's 60 to 120 hours, once daily dosing with 250 to 500 milligrams, and there's no benefit in increasing the dose to greater than 500 milligrams. The reason I use 500 is if I get a call from a patient's partner is that they drank on 250 milligrams and nothing happened, I'll increase the dose to 500, but I do not go beyond 500. Always warn patients about hidden alcohol in cough syrups, back rubs, cooking wines, hand sanitizers. And disulfiram administration should never take place until the patient has abstained from alcohol for at least 12 hours. And patients should avoid alcohol and alcohol-containing products for at least 14 days after discontinuing disulfiram. Cannot start disulfiram if baseline LFTs are greater than 3 times the upper limit of normal and the total bilirubin is greater than 3 milligrams per deciliter. In the transplant population, we do not initiate disulfiram if the MEL score is greater than 20 and the Maddrey's discriminant factor is greater than 32. And chronic therapy is associated with liver enzyme elevations in about a quarter of the patients. And the estimated incidence of acute liver injury is about 1 per 10,000 to 30,000 patient years of disulfiram of treatment. And the liver injury usually rises between 2 to 12 weeks. So if after 12 weeks patients are doing well, the likelihood of a liver injury is very, very remote. So a meta-analysis of 22 randomized controlled trials, N of over 2,400 patients, compared the success for disulfiram and controls. Success was defined at total abstinence, percentage of absent days, mean days of alcohol use, and the likelihood of no relapse, and longer time to first heavy drinking day or 3 or more weeks of consecutive abstinence. And disulfiram was estimated with a higher success rate than controls, only in open label studies with no statistically significant difference in blinded trials. Even though there was no statistically significant difference in blinded trials, the medical outcomes for patients in blinded trials were better as compared to patients on active disulfiram as compared to the ones on placebo. The next FDA-approved agent, naltrexone. Naltrexone is a full antagonist of the mu-opioid receptor and the kappa opioid receptor, and to a lesser extent, the delta opioid receptor. Is approved for treatment of alcohol use disorders in 1994 under the brand name of Revia. It reduces drinking via several mechanisms. It reduces the positively reinforcing effects of alcohol by reducing the mesolimbic opioidogenic activity. It enhances the sedative effects of alcohol. And for a small subset of our patients, it decreases cravings. So when generally when I talk to medical students and residents, their impression is, oh, naltrexone helps with cravings. Yes, it does, but for a very small subset of our patients. The greatest value of naltrexone is it blocks the positively reinforcing effects of alcohol. When patients do well on naltrexone, they come back and say, what the reports I get from patients is, Dr. Wakhlu, when I drink on naltrexone, I can have 1 or 2 and I'm done. There's a sense of early satiety. It's not so much decreasing craving, is that it minimizes the possibility of people that loss of control. It puts the brakes on loss of control, so people don't go from 2 to 4 to 6 to 8 drinks. That is the greatest value of naltrexone. And the second bullet point there, people become sleepy when they drink on naltrexone, so it terminates drinking, and that's the way. And for a subset, I would say about 20% of the patients, it does really decrease cravings, but not for a large majority of the patients. Yeah, the like I said, the greatest value is a sense of satiety and a brakes on the loss of control of alcohol use. I generally start patients on 25 milligrams at bedtime for 7 days, increase to 50 milligrams at bedtime, and for a subset of the population, I may increase the dose to 100 milligrams if needed. Now, targeted as needed dosing may be a useful strategy for promoting adherence in young individuals who prefer to take the medications on an as needed basis. So I have a subset of patients in the age groups of 25 to 50 that really have an alcohol use disorder but really don't want to stop because alcohol is a social glue for them. It's really important for them to have their friendships and relationships. So, but they are concerned about their level of drinking and do want to drink less. So there's a value of naltrexone even in for people who don't want to stop but who want to drink in a safer manner. And there's also a value for alcohol for those 40 million people I talked about in the earlier slide who have unsafe alcohol use. So you can convert them from unsafe alcohol use to safer alcohol use. Naltrexone has an active metabolite, 6-beta naltrexone. The half-life of naltrexone is 4 hours. Half-life of 6-beta naltrexone is 13 hours. And time to peak plasma levels is about 60 minutes. Obtain baseline LFTs LFTs at baseline and then every 6 months, and cannot start naltrexone if the baseline LFTs are greater than 3 times the upper limit of normal and the total bilirubin is greater than 3 milligrams per deciliter. And in the transplant population, like desulfuran, do not initiate desulfuran if MELD is greater than 20 and the matrix discriminant factor is greater than 32. I worry less about the liver and naltrexone as compared to the disulfiram. So, and I really like more than just the liver enzymes. I really like to look at this liver synthetic functions, the total bilirubin and the PT-INR rather than just the liver enzymes. Side effect profile is benign. Common side effects are nausea, sedation, headaches, dizziness. Because of that sedation, that's why I do a bedtime dosing for naltrexone rather than a morning dosing. And in sedation, it's not like prescribing someone trazodone and they can't put you to sleep, but it just makes them they want to take a nap. So that's the kind of level of sedation that patients experience. Health patient abstained as well as decreased alcohol use, and a meta-analysis of 16 studies over 2,300 patients showed a risk decrease for return to any drinking associated with naltrexone 50 milligrams daily. Naltrexone was also associated with reduced risk of binge drinking. Next, I'm talking about the depot naltrexone or Vivitrol, which is the intramuscular preparation of naltrexone. It's a Medisob drug delivery technology. Naltrexone is embedded within biodegradable polymer microspheres released over at least 30 days. The recommended dose is 380 milligrams every 4 weeks IM in the gluteal region. So when you combine the powder and the liquid, it makes about 4.2 cc's. And there's not enough muscle mass in the deltoid area to give it. So it has to be given in the gluteal region, the upper outer, the ventrolateral aspect of the gluteal region. It has 2 peaks, 2 hours and 3 days. The elimination half-life of naltrexone and 6-beta naltrexone following IM injection is about 5 to 10 days. And after day 14, levels tend to decline. And for some patients, effects wear off between day 21 to day 24, and patients may need additional treatment with oral naltrexone till they're due for their next injection. So I always give patients that I switch over to the injectable formulation, I always give them a 90-day supply of oral naltrexone tablets that they may need to take for the last week till they're due for their next injection. It clearly improves compliance with treatment, hepatically safer because it bypasses the first pass metabolism. Like the oral tablets, helps people abstain as well as decreases alcohol use, and common side effects are similar: nausea, fatigue, decreased appetite, and serious injection site reactions from post-marketing surveillance, including induration, cellulitis, hematoma, abscesses, and necrosis, and females appear to be at a higher risk for these reactions. In a placebo-controlled trial of the injectable naltrexone, the mean monthly number of binge drinking days declined by 13.3 in the placebo group to 6 days per month, 14.8 in the 190 milligrams group to 4.5 days per month, and 16.2 in the 380 milligrams group to 3.1 days per month. So the decrease in the 380 milligram group was significantly greater than in the placebo group. So the next agent, again, gabapentin, not FDA approved, but clinically proven to be very efficacious. Gabapentin binds to the auxiliary alpha-2 delta subunit of the voltage-dependent calcium channel, which inhibit invert calcium currents and attenuate neurotransmitter release of excitatory neurotransmitters glutamate and norepinephrine on the ascending neurons in the CNS. Half-life is about 5 to 7 hours. Time to peak plasma concentration is 2 to 4 hours, and it's absorbed by means of a saturable amino acid transport systems in the gut. So it has non-linear pharmacokinetics, and there's a next slide that I'll talk about and how the bioavailability versus with dose. And gabapentin serum levels is minimally elevated once a total daily dose of 2400 is surpassed. So really, there's no value, clinical value, in going beyond 2400 milligrams of gabapentin, and it does not bind to plasma proteins. So this is what I was talking about earlier. As you can see, in the total 900 milligrams dose, the percentage bioavailability is about 60%, 1200 is 47%, 2400 is 34%. So after 2400, as you can see, the bioavailability doesn't really shift much. So again, clinically, is there a value in going up beyond 2400? It's a big question mark there. Gabapentin is reported to reduce alcohol consumption, improve sleep, and decrease alcohol craving in subjects with alcohol use disorders. And the next two studies that you see there are primarily, both these studies came from MUSC in Charleston, and there was a gap of 10 years between the two studies. And the first study was done in about 2012. The second study was done in 2022. The first study was compared naltrexone, gabapentin plus naltrexone and placebo. It found additive effects of the combination improvements in sleep in the combined medication group in the dose range of 900 to 1800 milligrams per day. The second study, which was done a decade later, showed that gabapentin titrated to 1200 milligrams per day is efficacious in promoting abstinence and reducing drinking in patients with alcohol use disorder, especially those with more alcohol withdrawal symptoms. And as we have seen in our clinical practice, even monotherapy with gabapentin has really a value in helping people decrease withdrawal symptoms, decrease cravings, and improve sleep. And gabapentin has been shown to increase slow wave sleep as well as decrease spontaneous arousal index. So again, a word of caution: patients with opioid use disorders or benzodiazepines use disorder are at an increased risk of abusing gabapentin. So again, a cautious use in that population. And the last agent I'm going to talk about is topiramate. Topiramate, originally synthesized as an anti-diabetic agent, approved for treatment for partial onset and generalized tonic-clonic seizures. Its bioavailability is about 80%. Half-life is 19 to 23 hours. It has no hepatic metabolism like gabapentin. It's about 50 to 80% excreted unchanged in urine. It increases GABA-A facilitated neuronal activity, antagonizes AMP and kainate glutamate receptors, and reduces the cellular release of dopamine in the mesocortical region. And also, topiramate inhibits carbonic anhydrase, and that is a mechanism that is responsible for nephrolithiasis that we see in some patients, or stone formation that we see in some patients. It's been shown in large-scale randomized placebo-controlled trials to reduce heavy drinking and promote abstinence and decrease the medical consequences of alcoholism. So this is the dosing protocol I like to use. All of us who are familiar with using topiramate, it's always kind of going low and going slow with topiramate is a wise thing to do, because if it's a side effect profile. So week one, I start people on 25 milligrams daily and then gradually titrate it up. At the end of 4 weeks, patients are taking 100 milligrams daily in divided doses, 25 milligrams in the morning and 75 at bedtime. And the target is 200 to 300 milligrams in 8 to 12 weeks. And not everyone needs a target dose. There are people who will respond to 100, 150 milligrams, but if you need to go higher, you can. So common adverse effects are paresthesias, taste perversion. People feel food tastes different, anorexia, and nephrolithiasis or stone formation, and decreased cognition. We are all familiar with the decreased cognition. People report cognitive dulling. A ketogenic diet increases the risk of nephrolithiasis. Fetal exposure to topiramate has been associated with the increased incidence of congenital malformations. And of small for size gestational age. So again, if you have female patients, childbearing age, something to be mindful of. It's not FDA approved, but its use is endorsed by NIAAA based on the strong evidence for efficacy. And this is a recent study done by Morley and her group in Australia. It is a recent 12-week multi-site randomized controlled trials comparing topiramate versus naltrexone for alcohol use disorders, which showed that topiramate is at least as effective and safe as naltrexone for reducing alcohol consumption. Greater effects of topiramate in standard drinks per drinking day over time. Topiramate was superior to naltrexone in reducing alcohol cravings, GGD levels, and the rate of BMI reduction was greater in the topiramate group. As we all know, topiramate is used as a weight loss medication, either in monotherapy or is in combination with phentermine, which the brand name of Cosima. So there's a and we see this clinically as people stop drinking, they have a lot of sugar cravings and tend to gain weight. So a really added advantage of using topiramate in this population. My last few slides, future developments, again, psychedelics. I'm not going to talk about details in this, and then this interest in ketamine. And then, of course, we have the neurokinin 1 receptor and neurokinin 3 receptor antagonist. And my last slide is this is the pharmacotherapy algorithm that I've developed when I teach residents and medical students and fellows. This is what I talk about. So, and again, kind of moving away from acamprosate. And again, for baclofen and prazosin also, we don't have much. There is some evidence, but not much evidence. So basically, disulfiram, naltrexone, gabapentin, and topiramate are what I consider first-line agents for treating this patient population. So I will stop now and open it up for questions. Yeah.
Thank you, Dr. Wakhlu. And I echo what he just said. Do we have any questions for him on his presentation for today?
I have a question. Is there anything we can do to help reduce the increasing the young girls in their alcohol use disorder trend?
Trend would be basically, I think trend would start at the middle school and high school is just education prevention. I think that's really a focus. Again, recognizing for clinical care, recognizing the red flags of early mild to moderate alcohol use, which we tend to fail to recognize. For example, if we have if you're seeing a female patient and her depression, anxiety, insomnia are not getting better, you had made multiple trials and they're not getting better, always drug and alcohol use disorder should always come up in your differential. There was a beautiful study done that showed that 30% of patients that were diagnosed with TRD or treatment-resistant depression had an underlying alcohol and drug use disorder that was not diagnosed. So I think those are things, and education. I mean, it's you'll be surprised, Dr. Lochner, how many patients are not aware of what a standard drink is. Even a few years back, I had a nurse who. I was not seeing her for an alcohol use disorder. Her provider had retired, and I was just seeing her because she had not been seen for a while and she needed refills of medications. So she was a nurse manager in one of the UT Southwestern clinics, and I asked her, I said, "How much do you drink?" She said, "Well, yeah, Dr. Wakhlu, I don't drink much. Just on Friday, I have a couple of glasses." And then I rephrased my question. I said, "How much time does it take for you to finish a bottle of wine?" She said, "That Friday, I finished the entire bottle." And so I told her, I said, you're not drinking 2 standard drinks, you're drinking 5 standard drinks. And that was a total surprise to her. And then she realized, she said, yeah, next morning when I wake up, I don't feel very good. My sleep is not very good and I kind of feel dysphoric. So I think education is the key. And, this phenomena of red wine and heart health is still prevalent. People still believe. I mean, I kind of fail to understand why that is, but it still exists that red wine is good for heart health, which is far from the truth.
Thank you for that question. I do see Dana's hand raised. If you could unmute before we go ahead and move to announcements and ask your
Yes.
question. Thank you.
Yes. So, doctor, my question has to do with the topiramate. I'm not saying it correctly. So as opposed to naltrexone, so let's say we have someone that's diabetic too, and does the topiramate, the naltrexone seems to like calm them from what they report and helps them sleep at night? I saw gabapentin improve sleep, but topiramate, does it have the same calming effect as naltrexone, I guess, to sleep? Is my question.
No, that's not been my clinical experience. I have not seen a kind of a sedative or a hypnotic effect of topiramate. It does not improve. The patients don't talk about the fact that it improves their sleep. Yeah, absolutely. That's definitely that's why I dose it in divided doses in the morning and bedtime. Yes, it does not have an effect on sleep. Yeah.
I asked that because many people that I've seen report, they started drinking at night to help them sleep, which of course was a rebound effect. but so sleep is kind of an issue with some of the folks that we work with,
Oh,
obviously.
absolutely. I am. But I mean, post withdrawals, the sleep is a very common, very common issue. And what I have realized over the years is that combination therapies for alcohol use disorders are definitely superior as compared to monotherapy. So if you have someone on topiramate, you can always add gabapentin and really there's an added benefit of adding a medication which can help them sleep as well as further decrease craving and kind of an anxiety. So always, I most of my patients are on combination therapies rather than monotherapies.
Thank you all. Thank you for your participation. In the interest of time, we're going to go ahead and move on to announcements. But Dr. Wakhlu, I would like to bring your attention to the chat as there were some questions directed to you. If you could address those in the chat for us. And Karen, if you can bring up the announcements, please. Thank you very much. So to claim your CME credit, you must text by midnight tonight. You text attend 100-98219 to the number on the screen. And this information will also be shared in the chat. Next slide, please. The 2025 Texas Substance Use Symposium is officially open for registration. This free event will feature complimentary continuing education curricula, interactive panel discussions, and professional networking with national and Texas-based substance use disorder experts. For more information, use the link in the chat, please. Next slide. And Texas US 2025 is officially open to sponsors and exhibitors. This will be taking place February 27th to the 28th in El Paso, Texas. And if you're interested in learning more on how to become a sponsor or exhibitor, please visit the site that is shared in the chat. Next slide, please. Join us tomorrow, January 10th, for our webinar session with our very own hub member, Dr. John Weems. Please register using the link in the chat. And finally, please join us at our next session on January 23rd with Dr. Shorter for a session on medications for stimulant and nicotine use disorders. Thank you very much, Karen. And so before we move on to our case today, I would like to remind everyone that no protected health information is allowed in either the chat or the discussion. And let us continue making the space inclusive and open to respectful dialogue. With that, Dr. Luckner, once Karen shares the case form, please walk us through it.
All right. That was a very helpful presentation. I wish that I'd heard that a lot earlier. I mean, I typically haven't found very good benefit from some of the medications for alcohol use disorder. No successes with that. But I can see that there are many opportunities to dose more appropriately and perhaps use combinations of medications that look very promising to me. And this is just comparing the presentation to say what you would find in UpToDate under the the dosing. So I'm going to give a presentation for a 37-year-old male with multiple psychiatric and medical conditions, as well as alcohol use disorder. It's also a case of relapse. The patient had a period of sobriety, then relapsed. He had pretty significant depression and anxiety, poor sleep, and currently he is in a relapse situation. He's had a lot of depression, sleep disruption, averaging, he would complain about averaging 2 to 3 hours of sleep per night with frequent nightmares. And then he also has suicidal ideation, sort of chronic suicidal ideation with no plan or intent, but he just feels really symptomatic in terms of his depression, and sometimes feels like he just wants to escape it all. In terms of psychiatric assessment scores, his PHQ-9 was a 9 out of 27, moderate depression most recently. And then a few months ago, it was higher, more in the teens. G87 was up in the high range as well previously, now 7 out of 21, improved with some of the recent visits. He has significant PTSD type symptoms. I've diagnosed him with PTSD and those, recurrent nightmares, that kind of thing. And he also has ADHD with very symptomatic presentation early on and improved with stimulants. In terms of his past medical history, he has bipolar disorder. Current episode is depressed. He had a manic episode about 6 months ago. PTSD with chronic nightmares, ADHD combined type, social anxiety disorder. He doesn't feel comfortable in groups. He doesn't feel comfortable going to Walmart, places like that. He also has a sort of a panic disorder where his anxiety will get so severe that he'll have chest pain and heart racing and, very, very distressed. And of course, the alcohol use disorder, a very heavy daily alcohol use in the past. I was able to work with him initially, and he achieved sobriety for about 3 months, and then he relapsed. And during the relapse period, it was really hard to get him to come in for appointments. And when he did come in for appointments, there was an overwhelming amount of I guess you could say, drama that he was telling me about. And it was really hard to really just focus on the alcohol use itself. In terms of medical conditions, he has hypertension, and just kind of a point of reference. What I notice is that patients that have treatment-resistant hypertension, they sometimes have heavy alcohol use as well. So that's another sort of tip-off. If you have treatment-resistant depression or hypertension, that there might be a substance use disorder. He has GERD with esophagitis. He's a former smoker who quit 10 years ago, has COPD, chronic pain, testicular hyperfunction, and anhidrosis, which is kind of minor but really annoying to him. Psychiatric medications, he's on Abilify, 10 milligrams daily BID, fluoxetine, 10 milligrams daily, buspirone, 10 milligrams. I always tell people to take a TID, but people forget, and it's at best they're taking it once or twice a day. He's on Adderall, generic dextroamphetamine, 50 milligrams daily. Clonidine has also been very helpful for him. I always use the patches. I never use the immediate release for the stress it puts on heart. So with the patch, I do feel comfortable prescribing it. Propranolol has been very helpful to him, 20 milligrams. It's not well, he can take it daily. He can take it basically from 1 to 4 times a day, and he's found that helps a lot. His GERD is treated with esomeprazole. He has albuterol for his COPD. In terms of this clinical course, we've increased his Abilify. We also added fluoxetine. He's had poor adherence to naltrexone. He says it doesn't really reduce his cravings. My impression was that it reduced cravings, and he said it didn't. And from this presentation today, I can see that's actually something I wish I'd have known sooner. Also, prazosin for night terrors, but it causes grogginess in the morning, so he hasn't been taking it. His weight fluctuates. He's overweight. He's had a 12-pound weight gain. He's had financial constraints. Initially, he was uninsured, so it made it difficult in terms of what medications I could prescribe, and just him coming to appointments as well for the doctor's visits. Here in the rural Texas Panhandle, we have something like a 24-month psychiatry wait list. I mean, obviously, if you have a lot of money and you have great insurance, then it's not as long. But I think even in many ideal cases, it's 6 months. There's limited social support, poor medication adherence. There's also just generally very poor healthcare knowledge in terms of immediate interventions. I'd like to do weekly follow-up visits, but for safety monitoring, but he really only comes when he needs refills for his stimulant. So that's really been kind of a major issue. He's a very nice guy, but he doesn't like to come to doctor's appointments. I really need to optimize his medications. I'd like to get him into therapy, but again, he doesn't have a lot of money, and therapists are hard to come by. And the ones that you do get when you don't have a lot of money are often not very successful in helping achieve goals for therapy. He's got a safety plan. He really doesn't complain about suicidality unless you just directly ask him. I want to stabilize his mood and sleep. He has sleep apnea, but again, it's hard to get him into a sleep study and get him the appropriate treatment. I want to maintain sobriety, improve medication adherence, address the social isolation. So questions for discussion. One of them is medication optimization strategies. Given the complexity and adherence issues, what strategies can we use to improve this patient's regimen? Alcohol use disorder, how can we best manage his alcohol use disorder, considering limited specialist access? And finally, resource and support systems. What additional resources or support systems could benefit this patient? And I'll open it up for questions.
Thank you, Dr. Luckner, for bringing this case to us. And yes, the floor is now open for any questions from our audience or our hub members.
I just had one question about the bipolar disorder pharmacotherapy and if other medications have been used besides Abilify, and if the maximum dosage of Abilify he's taken is 20 milligrams a day.
That's a great question. I usually, if I have somebody with bipolar, they're not on any medications, I usually use Seroquel or quetiapine. Sorry, I'm using all these brand names. I apologize. I'm in primary care. Yeah, so we started with Seroquel. He really didn't like it. He found it very sedating. He says that sometimes he sleeps like 18 hours a day. So the Seroquel really wasn't helping us there. So we switched to Abilify, and I've been carefully titrating. One of my family members had a psychiatric condition, and they complained about being on Abilify 40 milligrams. And ever since then, I've been kind of hesitant with Abilify, but please encourage me to do the right thing.
Yeah, I was just thinking about the depression that's present, how it was severe. The patient's coming out of a manic episode. The depression is still quite prominent, actually. Abilify is a great medication. It's FDA approved for treatment of bipolar depression, but just optimizing the dose there could be really helpful. SSRIs tend to not necessarily be as effective for treating bipolar depression. And so how much bang for your buck you'll get out of fluoxetine will kind of is yet to be seen. If going for an SSRI, sertraline could be an option here because it is FDA approved for treatment of PTSD. And also there was a study that looked at the combination of sertraline and naltrexone. And they used pretty high doses of those medications in the study. They got the sertraline up to 200 milligrams a day. They got the naltrexone up to 100 milligram a day, but found that the combination of sertraline plus naltrexone was actually superior to either medication as monotherapy. Now that was, of course, looking at major depressive depressive disorder and with comorbid alcohol use disorder. You're dealing with bipolar depression with comorbid alcohol use disorder. So there's going to be some more art rather than science when it comes to what you're looking for with that kind of combination of medications, but really optimizing both the treatment for bipolar depression and then maybe thinking about the SSRI and the relationship of that to both alcohol depressive symptoms could be really helpful here, as well as PTSD.
What about the anxiety, the panic disorder? I mean, I really try to avoid benzos. Some people use them for that. Any thoughts?
Absolutely. So I'm going to actually toss back to Dr. Wakhlu's presentation and maybe offer that gabapentin could be really helpful here for both the comorbid anxiety that he's experiencing, as well as alcohol use disorder or alcohol related symptoms. It could be helpful with reducing anxiety as well as improving quality of sleep and that sort of things. Now, I mean, I am an addiction psychiatrist, so I get really curious about things like the nightmares and sort of the quality of the dreams that he's experiencing. I know on the second line of therapy that Dr. Wakhlu mentioned, there is prazosin. Prazosin has weak evidence for treatment of nightmares in the context of PTSD. And I've recognized the sort of limitations in access to psychotherapy, evidence-based psychotherapy, trauma-informed or trauma-focused psychotherapy. But something like imagery rehearsal therapy can be really helpful. It is an evidence-based psychotherapy that really helps to target nightmares in the context of PTSD. But I'll let some other people jump in with some of their thoughts too. This is a really tough case. Excellent job.
And also, have you dove into the sleep apnea, CPAP, the quality of his sleep related to those comorbidities?
Right. We had some, the most common companies that were doing the sleep studies in this area were really, they had an interesting scheme. They charge insurance companies $600 and they charge the patient like $200 to $300 and it would be like $200 now. And then they come back and say, oh, by the way, we need more money. So we finally found some new people to do sleep studies that don't play games like that. And so we're able to get more people with the sleep studies, but then getting the devices, getting the insurance to approve it, it's sometimes a long process, but we are moving that direction with him. But the problem is that, you know, he doesn't want to come in for appointments. So I've got all these issues and, you know, a lot of, I think the sleep apnea definitely is something that's a good point. I mean, I can prioritize that certainly.
Dr. Luckner, first of all, very complicated patient, and you're doing a great job. So, kudos for that. I wanted to ask, is there any barriers to having injectable form of naltrexone for this patient, given that compliance is a concern and the patient only shows up like once a month or whenever they need a refill for their Adderall or other stimulants that they're on?
I mean, I think that I have really hadn't even considered it. And so that was one barrier, just knowledge. So a lot of times when I've tried injectable medications in the past, the insurance wouldn't approve it. And I'll give it a try, but that's usually the limitation is what the insurance will approve.
Mm-hmm.
Dr.
Yeah, given
Luckner.
this patient has, sorry,
Go
go ahead.
ahead, Doctor. No, just to Dr. Luckner's point, I have not yet had, of course, any. I work at UT Southwestern in a clinic that we accept Medicare and commercial insurances. I have not yet had any denial for Vivitrol request. So just to let you know, yeah. Sorry, Dr. Shaw.
Yeah, that's the point I was making that, especially given the patient has like private insurance, so it makes it less likely that you will end up with a denial. And Vivitrol is also I mean, I think if your clinic does IM injection, so it shouldn't be like a barrier on your end to actually administer that.
Not a problem.
Dr. Luckner, I have two questions. What does naltrexone do for him? It doesn't decrease his cravings, but does it decrease his daily alcohol use, or does it have any effect on the loss of control of his alcohol use?
When he was taking it, it seemed to, he was drinking, he was sober actually. So it was kind of exciting. He almost felt like, well, I don't need it, I'm sober. And I said, oh, keep taking it. I think he just, it's one of those, what's interesting about this case to me is the relapse phenomenon. I mean, he went from daily heavy drinking for decades to sobriety, and I think then all the emotions that were suppressed just kept coming up, and I think that eventually he just gave in. And so with the naltrexone, my idea was just to reduce the alcohol cravings, but apparently that's not. It has a much stronger effect in reducing the amount that alcoholics drink. I find it. When he said as much, the patient said that if he has one drink, he can't stop.
And that's true even with the naltrexone?
With the naltrexone, I felt like he was doing much better. So I think that maybe something like Vivitrol is actually a pretty exciting possibility in this case from my perspective.
What about his AA involvement? Does he go to AA, Smart Recovery?
No, very sort of anti-religious, and AA tends to be very, praise and, worship. No drugs. Don't take an naltrexone. It's bad. So no. I thought about maybe some non-religious type alternatives, but we're in the boonies here in the Texas Panhandle.
I guess I will offer
Sorry.
then, oh, sorry. I was just going to offer that the topiramate, again, like Dr. Wakley just mentioned, could be potentially helpful here if there is a component of mood instability. Now, we don't typically use topiramate for treating bipolar disorder, but if there is some mood lability, mood instability, topiramate can sometimes be helpful for that, in addition to also reducing alcohol-related behavior. So perhaps another plug for why, for this particular patient, topiramate could be an option.
Thank you.
I do see that Carlos Dostal did put a comment in the chat. Carlos, would you like to unmute and elaborate on that for Dr. Luckner?
Sure. Hi, I'm Carlos Ostal. I'm an internist doing addiction medicine at UTMB in Galveston, and this just reminds me of some of my patients who, just early recovery is they're so vulnerable in that time because they're oftentimes they are self-medicating some severe trauma, and as you mentioned, this patient has PTSD, and so in that early recovery time when they start having some of those. Thoughts and that are unpleasant coming back to them, that it's really important. I tell my patients that as addiction medicine providers, we extend our patients a lot of grace, but it's important for us to coach our patients to extend themselves some grace as well. And those feelings and thoughts that are uncomfortable are oftentimes symptoms of prior trauma that we have to work through. And I know, not and being here in Galveston, we also don't have a lot of access to like LCDCs and getting, there's wait lists and getting people into formal treatment like that can be difficult. But like for non-religious options, I heard Smart Recovery. I've downloaded the app myself. There are remote meetings that you can get into. I'm also a volunteer for the Phoenix, which is a fitness-based recovery peer support group as well. And that app has just stuff going on all the time. You can get into remote things on the Phoenix around the clock. And so there's mindfulness exercises that, they do at 10 a.m. every day. They call it Mug of Mindfulness. And oftentimes just setting aside that time during the day to basically bring forward some of your thoughts and things that you need to process can just make wonders and help you, sleep at night and keep you from having to deal with those overwhelming emotions later. And Vivitrol, sounded like was an excellent suggestion for this patient, I think. And yeah.
That was wonderful. Thank you, Dr. DeSalle, for sharing that with us. Thank you, Dr. Luckner, for sharing this case with all of us here today. In the interest of time, I'd like to defer to Dr. Wakhlu for a brief summary of recommendations, please.
Thank you so much, Angela. So today happened to be an interesting a case which was very much tied to the didactic that we had, and an excellent complex case that Dr. Lutner brought forward about the challenges of treatment of someone with an alcohol use disorder, significant psychiatric comorbidities, especially living in a rural area with limited access to mental health treatment and therapy options. So, and again, is that considering a combination of medications, trying combination therapies, trying long-acting injectables with modifications to the patient's treatment regimen, which may help with recovery. Again, the goal is definitely we want our goal is complete and total absence, but even reduction in alcohol use is a good goal to start with. And if medications for alcohol use disorders can help us do that, that helps us engage patients in long-term absence and recovery. And that's my summary. And
That
thank you,
was
Dr.
great.
Lucknow, for that great case. That I mean, this is a complex case that you're treating, and yeah, and you're welcome to shoot me an email or any of the hub members about any future recommendation that or future treatment. How the trajectory of the patient goes. We would love to hear about his course.
Thank you.
Yes, thank you, Dr. Wakhlu. Thank you to everyone that has attended today's session. As a reminder, to earn CE credits, please use the information that Karen has shared in the chat. And also, we kindly ask you to complete that post-session survey for some feedback on our sessions. So thank you all for joining, and we look forward to seeing you at the next session on January 23rd. Have a great rest of your day.